Crimean Congo Hemorrhagic Fever. Crimean Congo Hemorrhagic Fever CCHF. Introduction. Crimean Congo Hemorrhagic Fever CCHF is a viral hemorrhagic fever of the norovirus group. The disease was first described in the Crimea, former USSR, in 1944 and given the name Crimean hemorrhagic fever. In 1969, it was recognized that the pathogen causing Crimean hemorrhagic fever was the same as the responsible for an illness identified in 1956 in the Congo, and linkage of the two places name resulted in the current name for the disease and the virus. The geographic range of CCHF virus is the most extensive among the tick-borne viruses that affect human health and the second most widespread among all medically important herbivoruses after dengue virus. The disease is endemic in many countries in Africa, Europe, Middle East, and Central Asia, with sporadic outbreak recorded in Kosovo, Albania, Iran, and Turkey. In India, the first laboratory confirmed case was reported on 19 January 2011 in Gujarat. In India, neighboring Pakistan reported 56 cases annually. CCHF outbreak constitute a threat to public health service because of its epidemic potential is high. Case fatality ratio 10 to 40%. Its potential for nosocomial hospital-acquired infection outbreak and the difficult in the treatment and prevention. Epidemiology. Causative agent. CCHF virus belong to family Buonaviridae, genus Norovirus. It is an enveloped single-stranded negative sense RNA virus with tripartite genome. Since it is an enveloped virus, it can be readily inactivated. Suitable disinfectant solution include 1% sodium hypochlorite, 10% aqueous solution of household bleach, solution of glutaraldehyde 2% or as recommended by the manufacturer, and phenolic disinfectants 0.5 to 3%. Soap and detergent can also inactivate the virus and should be used liberally for washing hands. The virus gets inactivated by heating at 56 degrees Celsius for 30 minutes. CCHF virus is stable for up to 10 days in blood kept at 40 degrees Celsius. Vector. Tick are arthropods which suck blood from animal and human. A number of tick genera are capable of becoming infected with CCHF virus, but the most efficient and common vector of CCHF are the member of Hyeloma genus, the family Jodidae. The ticks are also natural reservoir of CCHF virus. The Hyeloma ticks are hard ticks, can be easily distinguished by four pair of legs in adult and lack of clear segmentation of the body. The adult ticks are flat and oval in shape. The ticks have four life stages: wise, egg, larva, nymph, and adult. Larva, nymph, and adult need blood meal for their maturation. Both larva and nymph largely feed on lower vertebrae such as rodent, rabbit, hare, etc., while the adult feed on higher vertebrae such as cattle, goats, sheep, etc. Male and female ticks suck blood. Both male and female can act as a vector for disease transmission. Trans-ovarian transmission of the virus from infected female tick to offspring via egg. The egg stadial, i.e. from larvae to nymph to adult. Transmission have been demonstrated among some vector species, indicating a mechanism which may contribute to maintaining the circulation of the virus in nature. Reservoir. Reservoir. Heart tick are the reservoir and the vector of CCHF virus. In addition, infected animal may also act as a reservoir during the period of viremia. The CCHF virus may infect a wide range of wild animal and domestic ruminant animals such as hare, rat, camel, cattle, sheep, and goat. Many birds are resistant to infection, but ostriches are susceptible and may show a high prevalence of infection in endemic area. Animals become infected with CCHF from the bite of infected tick. The most important source of for acoustic of the virus by tick is believed to be infected small vertebrae on which immature hylomatics feed. Domestic ruminant animals such as cattle, sheep and goat are viremic for around 1 week after becoming infected. Environmental factor. Environmental factor. Ecological change, poverty, social instability, poor health service, and absence of standard infection control practice have contributed to increased transmission of the CCHF virus. Mode of transmission. Mode of transmission. Animal to human transmission. Human being may acquire the CCHF virus by direct contact with blood or other tissue of infected livestock, or they may they may become infected through a tick bite or crushing of infected tick. Meat itself is not a risk because the virus is inactivated by post-slaughter acidification of the tissue and would not survive cooking. Human to human transmission. Human can become infected if blood, body fluid, and washed from patient with the disease come into contact with broken skin or mucous membrane, as occur when medical care personnel sustain accidental needle stick injury. In advanced stage of the disease, aerosol contact of blood of the patient can also lead to transmission of the virus. Population at risk. In endemic countries, majority of cases have occurred in those involved with the livestock industry, such as agriculture workers, slaughterhouse workers, and veterinarians. Healthcare workers attending on suspect, or probable or confirmed CCHF case and not following contact precaution are at high risk of getting infection. Hospital acquired infection outbreak. Nosocomial spread have been reported in many countries. Transmission cycle. CCHF virus circulate in an enzootic tick vertebrate cycle, and there is no evidence that the virus caused disease in animal. Incubation period. The incubation period for the illness depend upon the mode of acoustic of the virus. Following infection by tick bite, the incubation period is usually 1 to 3 days with a maximum of 9 days. The incubation period following contact with infected blood or tissue is usually 5 to 6 days with a documented maximum of 13 days. Communicability. High infectious in the hospital setting. Nosocomial infection are common after exposure to blood and secretion. Susceptibility. Immunity after infection is probably lifelong. Clinical feature. Clinical feature. Onset of symptom is sudden with fever, malaise, dizziness, neck pain, stiffness, backache, headache, sore eye, and photophobia. There may be nausea, vomiting, and short throat early on, which may be accompanied by diarrhea and generalized abdominal pain. Over the next few days, the patient may experience sharp mood swings and may become confused and aggressive. After 2 or 4 days, the agitation may be replaced by sleepiness, depression, and lassitude, and the abdominal pain may localize to the right upper quadrant with detectable hepatomegaly, liver enlarged. Other clinical features include tachycardia, lymphadenopathy, and a petechial rash both on internal mucosal surface such as in the mouth and throat on the skin. The petechial may give way to ecchymosis like a petechial rash but covering large area and other hemorrhagic phenomena such as melena, bleeding from the upper bowel passage as altered blood in the feces, hematuria, blood in the urine, epistaxis, nosebleed, and bleeding from the gum. There is usually evidence of hepatitis. The severely ill may develop hepatorenal and pulmonary failure after the fifth day of illness. The mortality rate of CCHF is approximately 9 to 50%, with death occurring in the second week of illness. In those patients who recover, improvement generally begin on the 9th or 10th day after the onset of illness. The convalescence period begins in survivor about 10 to 20 days after the onset of illness. In the convalescent period, labile pulse, tachycardia, temporary or complete loss of air, polyneuritis, difficulty in breathing, xerostomia, poor vision, loss of hearing, and loss of memory have been reported. Differential diagnosis. The following diseases are to be considered in differential diagnosis: pandemic leg conformation, malaria, leptospirosis, rickettsia disease, meningococcemia, dengue, hemorrhagic fever, hemolytic uremic syndrome, and thrombocytopenic purpura. Tries. Patients are divided into three categories. Category A, those that have relatively mild disease level. These patients improve spontaneously in about day 10 of illness. Patient can be managed with supporting therapy and regular monitoring for worsening of symptoms. These patients do not require ribavirin. Category B, those who are in the first 5 days of illness and are severely ill with high grade fever, local and systemic bleeding manifestation, having alanine transaminase SGPT level of 150 IU or more, aspartate aminotransferase SGOT of 200 IU or more, platelet less than 50,000, or activate particle thromboplastin time APTT of 60 seconds or more. Even if the patient still look comparatively well at this stage, these clinical path value are marker of poor prognosis if recorded during the first 5 days of illness, and person in the group should be treated as soon as possible with ribavirin. Those who are recognized and treated early enough respond remarkable well to ribavirin. Category C. Patient first seen or recognized as CCHF after day 5 and are in comatose or terminal state with DIC and multi-organ failure. Treatment with ribavirin is indicated, but the prognosis is very poor. Category B, C patient, even if they subsequently test negative, should receive the full course of ribavirin. Pre-hospital care. Supportive care is based on the patient's physiological condition because most patients requiring pre-hospital evaluation and transport are in the early stage of the disease. Universal precautions should be adequate in patients with respiratory symptoms, example cough, rhinitis, use facial and high efficiency particulate air HEPA filter marks. The ambulance should be disinfected after patient transportation with bleach or sodium hypochlorite solution. Care in hospital settings. Supportive therapy. General supportive therapy is the mainstay of patient management in CCHF. Intensive monitoring to guide volume and blood component replacement is required. Supportive care include fluid management by transvenous crystalloid oxygen, cardiac monitoring, and administration of blood and blood product as clinically indicated. Avoid intramuscular injection and use of aspirin or other anticoagulants. Minimize invasive procedure because of the risk associated with viral transmission from sharp object. Case definition. Case definition. Suspect case. A patient with abrupt onset of high fever 38.5 degrees Celsius more than and one of the following symptoms several headache, malaria, nausea, vomiting and or diarrhea and or history of insectic bite within 14 days prior to the onset of symptoms or history of contact with tissue, blood or other biological fluid from a possible infected animal. Example: abattoir worker, livestock owner, veterinarians within 14 days prior to the onset of symptoms or history of exposure to a suspect probable or laboratory confirmed CCHF case within 14 days prior to onset of symptom contact of the patient including health care workers. Probable case. A probable CCHF case is defined as a suspected CCHF case fulfilling in addition the following criteria: thrombocytopenia less than 50,000 and two of the following hemorrhagic manifestation: hematoma at the injection site, petechial purpuric rash, rhinorrhea, hematemesis, hemoptysis, gastrointestinal hemorrhagic, gingival hemorrhage, or any other hemorrhagic manifestation in the absence of any known precipitating factor or for hemorrhagic manifestation. Confirmed case. Confirmed case. A confirmed CCHF case is defined as a case that fulfills the criteria for suspect or probable CCHF and in addition is laboratory confirmed with one of the following assay: detection by RT-PCR or CCHF virus genome in a clinical specimen confirmed by sequential of the PCR product, detection by ELISA or IFA of specific IgM antibody against CCHF virus or a fourfold increase in specific IgG antibodies against CCHF virus in two specimens collected in the acute and convalescence phase. CCHF virus isolation. Laboratory diagnosis. Laboratory diagnosis. As CCHF virus is classified as risk group for virus and hence the clinical samples should be handled in specially equipped high biosafety level laboratory. Sample collection: antemortem blood sample, serum or plasma, postmortem tissue sample, liver, spleen, bone marrow, kidney, lung, brain. In the first few days of illness, diagnosis is achieved by virus or genome detection in blood or tissue sample collection. Sample should be collected with all biosafety precautions and should be accompanied with detailed history of patient on the perform which can be obtained from the testing laboratory before dispatching the sample. Disinfected the outer surface of container using 100 dilution of bleach or 5% Lysol solution. Transportation of sample. Sample should be safety packed in triple container packing and should be transported under a cold chain to the reference laboratory with prior intimation. However, in the area where obtaining such a container is difficult, the sample can be sent as follows. The case sheet with complete information about the sample should be completely filled in. Case report from separate sheet and provided along with the sample. The blood sample should be kept in screw cap plastic vial with proper label. The sample containing vial should be kept in good quality plastic bag which should either be insulated by heat or tied with rubber band so that inside material if leaks should not come out of the bag. The plastic bag should be placed in another plastic container which should be sealed with adhesive tape. This carrier should then be placed in another plastic bag sealed with rubber band and be placed in a thermocol or vaccine carrier counting ice. If plastic container is not available, then good quality of double plastic bag can be used. The case sheet will contain information should be placed in a plastic bag or envelope and be pasted outside of the thermocol or vaccine container. Person handling the sample should wear a glove and a gown to avoid direct contact with the infectious material. After completing the packaging of sample, person should thoroughly wash hand the with soap and water. Before dispatching the container, bleach can be used for disinfection. A 100 dilution of bleach or 5 Lysol solution should be used to clean the outer surface of the container. Virus isolation. It should always be carried out in maximum biocontainment laboratory BSL-4. The virus may be isolated from blood or tissue specimen in the first 5 days of illness and grow in cell line. Molecular technique. The reverse transcriptase polymerase chain reaction RT-PCR is the test of choice for laboratory diagnosis of CCHF virus infection for detecting virus-specific genome. It is a sensitive and specific method. Specificity and sensitivity can be further enhanced by using automated real-time PCR. Viral antigen may often be detected in tissue sample using immunofluorescence or ELISA. Serology. IgG and IgM antibody may be detected in serum by enzyme-linked immunoassay. The ELISA from about day 6 of illness. IgM remain detectable for up to 4 months and IgG level decline but remain detectable for up to 5 years. Recent or current infection is confirmed by demonstration seroconversion or a fourfold or greater increases in antibody titer in paired serum sample or detection of IgM antibody by IgM capture ELISA in a single sample. Treatment and prophylaxis protocol. Treatment and prophylaxis protocol. Pharmaceutical intervention. There is currently no specific antiviral therapy for CCHF. However, ribavirin has been shown to inhibit in vitro viral replication in viral cell and reduce the mean time to death in a suckling mouse model of CCHF. Additionally, several case reports have been published that suggest oral or intravenous ribavirin is effective for treating CCHF infections. Ribavirin is a member of the nucleoside antimetabolite drug that interfere with duplication of viral genetic material. This is the only antiviral known to have some effect on the viruses causing VHF. IV low dose day 1 to 4, day 5 to 10 days. Oral box first. Treatment protocol for adult with CCHF disease. 2 mg loading dose 4 gram per day in 4 divided dose 6 hourly for 4 days. 2 gram per day in 4 divided dose for 6 hours. Dose recommended for children. IV oral. Adverse effect. The most common side effect of Ribavirin is mild to moderate hemolytic anemia, which is reversible anemia associated with ribavirin therapy is often asymptomatic and can be managed by monitoring blood count and serum biochemistry. Ribavirin administered as an intravenous bolus has been reported to induce rigor. Consequently, it is recommended that the drug be administered as an infusion over 10 to 50 minutes. There have been reports of pancytopenia and pancreatitis associated with use of intravenous ribavirin. Contraindication and precaution. Contraindication and precaution. Ribavirin is contraindicated for treatment in pregnant women. Ribavirin has demonstrated significant teratogenic and embryocidal potential in all animal species in which adequate studies have been conducted. It can be given to pregnant women only if the benefit of ribavirin therapy appear to outweigh any fetal risk. Given the high risk of CCHF related mortality, both of pregnant women and fetus, ribavirin still may be recommended. Ribavirin is contraindicated in patients with chronic anemia and hemoglobin level below 8 grams per dl and in patients with several renal impairment. The drug may accumulate in patients with impaired renal function. These patients should be carefully monitored during therapy with ribavirin or single-line symptom of toxicity such as anemia. Thank you.